Our final presentation of the day explores access to behavioral health care in Arizona. Our panel members will each have about 20 to 25 minutes to present. Then we will address questions from all three speakers around 2:35. First, we will hear from Dr. Bryna Koch from University of Arizona Rural Health Center, who will address the availability of providers in rural areas and strategies to increase the number of providers who are MAT trained and the number of certified peer family support specialists. Welcome, Bryna.
Hi, everybody. Thank you. I'm just going to share my screen real quick. And can you see that slideshow okay?
Yes.
Great. Well, hi, everyone. Thank you, Jeanette, for the introduction, and good afternoon and welcome to the next to last session of the conference. My name is Bryna Koch, and I'm speaking with you today to provide an overview of access to behavioral health care in rural Arizona. The objectives for the presentation today are to describe the availability of providers and facilities that provide behavioral health services and medication for opioid use disorder services in rural Arizona. And then I'll talk a little bit about the programs and policies and services that are working to improve access to behavioral health services across Arizona. Before I get started, I just want to express my gratitude to all the attendees participating, particularly the speakers who have shared their lived experiences and those speakers who provide direct clinical care. I'm going to be talking kind of at the aggregate and systems level, and so I just want to thank those folks for their work and sharing their experiences, because I think it's really important when we share kind of systems level data to not lose sight of the individual and community experiences. So as I said, I work at the Center for Rural Health. Our mission is to improve the health and wellness of Arizona's rural and underserved populations. We're located at the University of Arizona in the College of Public Health. And my background specifically and the area that I focus on at the Center for Rural Health is really on collecting data and conducting analysis about the health and behavioral health workforce across Arizona. But I do want to talk a little bit about the connections that we've heard a lot about today between behavioral and maternal health, and just emphasize that health overall and behavioral and maternal health are both shaped by the same underlying social, economic, and healthcare influences. And really, those influences are what we think about as the upstream factors in public health. We also know that both behavioral and maternal health and health outcomes are linked to exposures to intersecting oppressive and discriminatory systems, which limit opportunities for health in our state and country. As others have highlighted through the conference, there are also structural conditions, including stigma and punitive laws, that affect the health system's ability and willingness to meet what we know is the goal of public health and population health, of holistic public health and prevention-oriented strategies. Also highlighted throughout the sessions is really the contributions, the intersections and the contributing factors to maternal mortality, particularly substance use disorder and mental health conditions. And this is a chart from the Arizona Department of Health Services maternal mortality and morbidity report. I want to highlight this slide, which provides a kind of a systems overview that has been presented throughout the conference, but I do want to emphasize that we've added in specifically some midstream factors to this kind of social and ecological context for behavioral and maternal health. And these midstream factors really are about rural healthcare conditions. And so when we're thinking about access to healthcare in rural areas, we have to consider that there are fewer opportunities for preventive care. There are fewer primary care providers available in rural areas. There's a longer distance to travel to healthcare. There are also fewer specialist providers and fewer providers that can provide maternal health services. And also in general, the population in rural Arizona, there tends to be a higher percentage of uninsured individuals, as well as individuals who are insured via the state Medicaid program. Just a note on adverse childhood experiences, which has also been mentioned as one of those underlying contributing factors to negative behavioral health and maternal health outcomes. We've had several speakers highlight that Arizona has, a higher prevalence of their population that has experienced 2 or more ACEs compared to the national prevalence. And there is kind of a mix of data on what ACEs look like for rural compared to non-rural populations. Some national data does show that rural children have exposure to a higher number of ACEs compared to children in non-rural areas, but there are actually mixed findings in this area. Overall, in terms of the behavioral health needs in Arizona, we do know that access to behavioral health services for anyone who might need it in Arizona, we do see a pretty significant need in terms of our prevalence and the ability or lack of ability to get access to treatment. And this can be worse in rural areas. So overall in Arizona, we know about 20% of adults experienced a mental illness in the prior year. 7% of adults experienced a substance use disorder in the prior year. And almost 6% of adults experienced an alcohol use disorder in the prior year. So it's overall for Arizona. Nationally, when we look at differences between rural and non-rural areas in terms of substance use disorder, we find similar prevalence and incidence rates for some types of substances, but then we find differences for others. But particularly where we find the difference between rural and non-rural areas is in certain outcomes like suicide, infections, and opioid overdose opioid overdose deaths tend to be higher in rural areas compared to non-rural areas. And of course, this has been highlighted as well in some of the presentations, which is, as we know, opioid use disorder the prevalence has been increasing. We've also seen a parallel trend in terms of opioid use disorder at diagnosis or opioid use disorder diagnosis at delivery. But I want to emphasize that, of course, people can and do resolve substance abuse and use issues. 3 in 4 people do report resolving these issues, including pregnant women. And we know that effective treatments exist, and those have been highlighted across the various presentations at the conference. So what does access to care look like specifically in rural Arizona? So the first thing I want to highlight before we talk about access to care in rural Arizona is that the definitions of what we mean by rural might vary. And so what I have of this map right here on the slide is the Arizona Department of Health Services definition of rural. So their definition includes any county outside of Yuma, Maricopa, Pinal, and Pima. And so using this definition, up to a quarter of Arizona's residents can be considered as rural residents and live outside of a metro area. The rural areas are kind of characterized by low population density, larger physical spaces, longer travel distance, and time to metro areas. And really, when we're talking about access to care, this affects everything from primary care to specialty care, but it also really can impact coordination, communication, and the ability to have continuity of care, which is really important both for a behavioral health treatment and follow-up in the postpartum period. In rural Arizona, in terms of some of those underlying social and economic characteristics, sometimes what we call the social determinants of health, we do know that in rural areas, there's a higher percentage of the population that experiences poverty, a higher percentage uninsured. There tends to be lower on average education levels compared to non-rural areas. And as I've talked about, fewer healthcare providers and less access to social system supports and healthcare resources. But as with any community, I want to highlight that there are protective factors to build on, and that can be supportive and protective against risk for behavioral health conditions. And they include social connectedness, multi-generational families, community history, shared culture and language, the opportunities for social involvement, and a sense of community. And particularly for when we talk about rural Arizona, I want to emphasize that like any area, we're not talking about a homogeneous communities. So I really want to highlight that in Arizona, there are important regional differences in history, culture, language, and ethnicity. And that when we're thinking about kind of risk for behavioral health conditions, we really need to consider that history, which includes forced removal and colonization, particularly for indigenous communities in Arizona and communities in the US-Mexico border region. And so when we're talking about rural Arizona, I want to still kind of hold like this idea that we're not talking about homogeneous areas, we're talking about diverse communities with different experiences. And so in that light, I do want to encourage folks who might be participating from rural Arizona to share their experiences in their chat or add context. And then when I'm going to talk about services, chime in with any services that may be available as well. In terms of definitions of access to care, the one that we rely on at the Center for Rural Health is the timely use of personal health services to achieve the best health outcomes. And that includes features like affordability, availability, accommodation, if the care is acceptable, that is, if it's culturally appropriate and is comfortable for the patient, and is accessible. Are the services, so the workforce and the facilities, geographically proximal to the person that needs care? And when we're talking about geographic proximity, we do know that this affects people's ability to access healthcare. So the further away healthcare is, the less likely that someone is going to receive it. This disproportionately affects low income, low literacy, more rural and under-resourced communities. There's a cost to individuals and families when they have to access care that is not proximal. And they include economic costs, right? So taking unpaid time off work, possibly, the costs of gas and transportation. They include time costs, so the time to travel. If you're traveling over an hour for care, then that means you're traveling probably over 2 hours out of your day, which is a significant amount of time. And they can include social costs, in that when someone has to move or leave their community for care, they may be far away from their social resources or social support and their built-in kind of a social safety net in terms of their individual and family community relationships. When care isn't proximal, it decreases the likelihood of receiving preventive and primary care. And when the Department of Health and Human Services is calculating standards for health professional shortage areas, they use a travel standard of anything over 30 minutes as being excessively distant to reach for healthcare services. And again, as I mentioned earlier, barriers really affect the likelihood of receiving care, but also, affect communication and coordination, which again has that follow-on effect of maybe negatively impacting the continuity of care. Again, to focus in on the needs in Arizona, when the Arizona Department of Health Services and the Department of Health Services at the federal level look at the mental health needs in Arizona, they calculate mental health professional shortage areas based on the number of psychiatrist physicians in Arizona. And using that standard and that calculation, they find that 40%, so 3.4 million of Arizona's population lives in a mental health professional shortage area. And overall, as a state, we're only meeting 10% of our need, which is really low. At a national level, only 30% of need is met, which is also very low, but 10% is a third lower than that. We would need 218 just of psychiatrist practitioners to remove this designation in Arizona. At the Arizona Center for Rural Health, again, the area that I focus on is collecting and compiling professional licensure data in order to estimate the supply of behavioral health professionals, including those listed on the slide here. So in this case, I have chosen, I've excluded physician and nurse professionals who might participate in behavioral health care provision, but have included behavioral analysts, counselors, marriage and family therapists, social workers, and substance abuse counselors. So you can see that there's a pretty clear distribution clustering by just total count of these types of providers in Maricopa and Pima County. When you look at the ratio, you see that the ratio per population of these providers is the highest in Coconino, Pima, Maricopa, and Yavapai County. At the Center for Rural Health, we often use a sub-county definition of rural because we think that this accounts for some of the variations in some of our 15 counties. We're very large. You can have metro areas within those counties. So we use a sub-county definition of rural that's called the Rural Urban Commuting Area Code. And when we look at the distribution of this subset of behavioral health providers by sub-county rural designation, you can really see the difference and the lack of distribution of behavioral health service providers in the rural areas compared to the urban non-rural areas in Arizona. And really what you see is the ratio of providers per 10,000 is less than half in rural Arizona compared to urban Arizona. Focusing even more specifically on medication for opioid use disorder treatment and access to that treatment, we know that the medication for opioid use disorder is the recommended first-line treatment for pregnant people, and it has been shown to improve patient survival, increase retention and treatment. So it really has the positive health impacts for pregnant people with SUD. So I'm going to talk a little generally about MOUD, not specifically MOUD for pregnant individuals, just to provide the context of access to services in Arizona broadly. And so what we have is two types of MOUD providers. We have the opioid treatment locations, and we have the buprenorphine OBOT locations, which are the office-based opioid treatment locations. And so some of my colleagues at the Center for Rural Health and the Southwest Institute for Research on Women have mapped the MOUD locations in Arizona. And so this is where this is the distribution they found for OTP clinics in Arizona. So again, you can see that this basically, mirrors the clustering of these healthcare resources in our metro areas in Arizona. So greater number of the OTP clinics are concentrated in metro areas, as you might expect, because that's where the majority of the state population does live. When you look at the office-based outpatient treatment providers, you do get a better distribution across the state of MOUD in these OBOT locations. So just to go back to the slide, there are 56 OTP clinics at the time of this research, and there were just over 2,000 OBOT locations to access MOUD in Arizona. And again, you can see that these are also clustered in the metro non-rural areas of Arizona. But when you look at the ratios and you take into account the population, we do actually see that although these ratios, there's small numbers of these facilities per population, we do see that there's fairly even distribution through our metro and to our large and small rural, but where you really see the drop off in access is in isolated rural parts of Arizona. So that's really where I would say the attention, I think we need to improve and expand services everywhere, but really when we're looking at a difference in access to services, really the difference you see is in that rural to isolated rural areas. I'm going to quickly review some programs, policies, and strategies that are in place. I think some of these have been presented on in the conference or covered by others, so I'll probably go pretty quickly through them. If folks have other programs they want to link to in the chat, that would be great. Again, a lot of our work at the Center for Rural Health focuses on kind of the healthcare system and midstream factors, but I do just want to, refocus and even maybe if our work doesn't focus on, remind all of us that, some of these underlying contextual factors, those upstream factors like education and employment, are really the protective factors over the life course and adulthood that are going to help us prevent behavioral health issues from arising. So the first thing I want to highlight is a tool to find your local community coalition, because there are so many amazing substance abuse prevention and access to treatment coalitions that are really doing absolutely great work. There's a website here where you can find the coalition near you. There might be some coalition members participating today. If you have questions about getting linked up to a coalition in your area, you can email me and I will try to connect you to the folks that we work with across some of our programs. I want to highlight that there are loan repayment programs available for professionals, and particularly that behavioral health providers are eligible for these loan repayment programs. I think sometimes people think loan repayment and they think physician, nurses may be the only eligible, and that's just not true. AZDHS has the page on loan repayment, but there is loan repayment available for social workers, counselors, psychologists, and licensed marriage and family therapists, if you meet the other eligibility criteria. There is a certified nurse midwife program starting up at the University of Arizona. There are specific primary care scholarships for students entering primary care at one of the University of Arizona medical campuses. And those scholarships focus on bringing students back to serve in rural and underserved areas after they complete their residency. I want to emphasize the availability of doula and doula programs that offer culturally relevant support and training, and that really work to address the discrimination and racism that can be encountered in the health system when pregnant people seek care. Several Indigenous doula training programs as well, and I believe there is a voluntary certification process in place for doulas in Arizona. At the University of Arizona, we have the AZ Mentors program. The last speaker mentioned, not necessarily increasing the workforce, but providing more training and resources to the workforce that is already out there. And this is exactly what this MAT Mentors program does, which is it matches inexperienced with experienced providers for MAT to give them that mentorship. There's an ECHO training program available through Arizona State University as well. We have 2 workforce programs, again, in partnership with Access and others, that are really about training behavioral health paraprofessionals as well as peer support specialists, which I think are really important and invaluable workforce resources to build throughout the state. In some of the research we've done, we've found that really the OBOT location is the way to expand access in Arizona. And just by getting OBOT providers into federally qualified health centers, we could, all the federally qualified health centers in the state, we could really decrease rural drive time by over 50% to access services. These initiatives have been mentioned by other speakers, so I'll quickly go past that. There are some helplines that you can call for resources: 211, the OR line, the Confidential National Maternal Health Hotline, and then the Find Treatment Locator and the Find Naloxone Locator as well. And to wrap up, I just want to highlight that like I mentioned, my focus is on workforce data. And so these are the folks at the Center for Rural Health who helped me put together some of the other project, program, and resources that I listed in the slide. So I want to make sure to acknowledge them. And I can hop back on the chat to answer any questions because I wasn't able to read it, But thank you for inviting me today, and I'll pass it off to the next presenter.
Thanks, Dr. Koch. We'll be taking questions at the end of the session. That's okay. We can also do it in between if it's important, but okay. Next we have from the University of Arizona College of Medicine, Dr. Maria Manriquez, who will update us on how we can ensure that medical education prepares providers for the growing behavioral health needs in Arizona. Hi, Dr. Manriquez.
Hi, good afternoon. We're almost at the end of this conference that's been fantastic. I want to say hi to the village because all of you are working hard in this space and much appreciated. Thank you to the program committee for inviting me to this outstanding presentation. I've been in and out and able to hear many of the presentations, and they've all been fantastic. So from Bryna's macro level, I'd like to just kind of dive into the micro level and what we're doing here in Phoenix. So this is just essentially, I like this picture because it made me think of my patients. It also made me think of the providers that work in this space. And we have to be a little prickly, we've had to figure out how to evolve and use the majority of our, surface area to be able to make sure we have the nourishment and the needed substances to flourish. And so I chose this selection of photos from my PowerPoint presentation for this purpose. Let me try to get this to advance. So I have no disclosures. The grant work, however, that I have been doing is been funded from SAMHSA Access, the Bruce and Diane Howley Foundation, and then the Robert Corrigan Foundation. We're grateful and thankful to all of them. This is a national survey for drug use and health from 2019, and they were really good about breaking down into different race, ethnicity, and then gender population. But I think it's really important to see the number of patients that exist in the United States that struggle with substance use disorder, as well as those with mental health disorders, and then that Venn of 3.6%, which is equal to 4.6 million patients over the age of 18 struggling with both substance use disorder and mental health disorders. A little bit about us. Both Banner University Addiction Recovery Center and the Howley Empower Affirmation Legacy, dubbed HEAL, are programs developed to provide outpatient access to medical and behavioral health care. HEAL specifically provides addiction medicine, obstetric services, and behavioral health at one physical site, and that's in the Women's Institute at Banner University Medical Center. And then Beyond Addiction is a telementoring program that we have been running for approaching 2 years on helping to train the workforce, but also to develop that village and feeling that supported camaraderie that we need. So the problem, there's an increase in substance use. Few outpatient, as Bryna described, there's few outpatient site provides convenient co-located services for patients. They, you can imagine you have a patient that needs to go to an addiction medicine specialist, go to obstetrician, go to behavioral health, and it's all very hard to navigate. And then at some point you throw in a beautiful little baby and you've got all the additional appointments associated there. Finding sustainable funding has been a challenge, but we again have been grateful and blessed to have identified funders. And then up to 60% of our patients do have coexisting mental health disorders. And not all specialties are well versed in how to screen for mental health. And we've been trying to do a much better job in our residencies here in primary care. And that includes obstetrics and gynecology. And then the costs associated with unscreened, undiagnosed patients, or that they have limited prenatal care, poor maternal and neonatal outcomes, and then limited addiction medicine and behavioral health leads to relapse and sadly overdose. The solution is definitely closing the gap, providing those prenatal services that prepare birthing families to be successful in caring for their newborns and their family. Identifying that target audience, the women and their families who are experiencing substance use disorder during pregnancy. We have implemented at the Women's Institute to screen all pregnant women using the 4 Ps that have been discussed early in the conference. So this will help us identify substance use disorder, but also domestic violence and depression, anxiety. And then the cost savings, of course, is decreased hospitalization for mother and newborn, and decreased relapse to substance use, decreased maternal infant separation, and hopefully just, expanding their relationships with their families and their friends that can help guide them to long-lasting sobriety. Heal at BUMC is, we have for addiction medicine, we have an MD and a DNP. We're growing that. I have so I'm currently, to my knowledge, the only obstetrician gynecologist in addiction medicine dual certified physician, but I am just started training another obstetrician gynecologist, so that should be around the corner pretty soon. And we do have 2 DNPs that are helping us with this workload. Then in our behavioral health space, we have a psychologist and clinical therapist and several social workers that are providing direct counseling. We provide intensive outpatient programs, standard program groups, peer support, and wellness coaching. And then, of course, the traditional and group prenatal care is provided at our institution. And these are provided also by faculty, but as well, we are training our resident physicians to do the same. And fortunately, we've had support from Banner leadership, the CEO, and then the U of A College of Medicine dean. So with all those good things happening, we're able to provide some good stuff. The outcomes, we've had over 150 birthing patients cared for. We have IRB pending to let us look at this repository and give data that's needed. It's a little bit challenging when you're in a big system like Banner and then the University of Arizona to be able to get these IRBs. And when you talk about sensitive topics like addiction and pregnancy, we have to make sure all those I's are dotted and those T's are crossed, but we will be distributing information regarding gestational age at delivery, retention and program, reduction in substance use, and then neonates with reduced requirement of NICU. We're very much in collaboration with Hushabye Nursery. So a good percentage of our patients go to Hushabye Nursery out at hospital day 2, 3. That's been fantastic to have a reduced NICU environment for the babies. So the vision started definitely with appreciating that there was just a lack of care and providers that were able to address these issues. At the time that I signed up for my BUP waiver, I think there were only 150 people in Arizona that had a data waiver. Now it's well into, I think the previous slide showed over 2,000. Sadly, the majority of those 2,000 providers don't either one have the comfort or that is not the predominance of their practice. And so the telementoring and the coaching and the sponsoring are really, really important. And we provide that here as well. And I think Bryna had mentioned that as well in Tucson and what they're doing. But the vision is to be able to be there, to step into that space, which many of us were not trained. I was trained, over 20 years ago, and that was just not, we knew of it. It certainly wasn't the epidemic that it is today. But we were very siloed in our specialties. And I think integrated care and collaborative care are just fantastic. One model we have is we borrow some time from our psychiatrist through one of our grants, and we review diagnoses and medications that they're on and any adjustments they may need. And then with our RNs, we do care collaboration. So frequently it enables us to be able to see more patients but also engages the patient with our RN navigators so that they can be readily available and empowered to help treat. Access anywhere is definitely part of our vision. You know, treatment based on evidence-based medicine, telehealth. We use a lot of telehealth. I think that was the silver lining all of us appreciated from COVID, is getting comfortable with doing that, learning how to bill for it. But you learned a lot about your patients too. You saw them in their home environments and what they were struggling with and what they needed, and even basic phone bandwidth, childcare, transportation, all of those were really broadly highlighted. And then of course, PDCA process to making sure that what we are doing is evaluated and improved on regularly. I did want to highlight, and Bryna did as well, the University of Arizona Comprehensive Pain and Addiction Center. So this was part of our strategic mission of the University of Arizona Health Sciences. And we submitted to the provost as well as the president of the university a need for this type of center. And that was approved in 2017. And finally has rolled out more recently. COVID kind of put everything on hold there for a second. But this is really looking at research and alternative pain management, drug discovery, new treatments and rehabilitation approaches, building preventative tools to screen at-risk patients, education. I think we've talked a lot about that. Both the Tucson and Phoenix University of Arizona College of Medicine have addiction medicine fellowships now. We are committed to making sure, along with the state, to educating all of our provider levels, so our nurse practitioners, medical students, in how to manage pain and substance use disorder, with the goal of each of them being eligible for data waiver immediately after graduation. Two projects that exist are the Project Future and the PeerWorks. This is just an outstanding opportunity for individuals to get more training. We are working with them to bring hopefully one of the PeerWorks to our site so that they can do their apprenticeship with us and then hopefully be one of our future peer support persons. And then the Arizona Rural and Opioid Response Implementation. Clinically in Tucson, there is a neonatal abstinence syndrome program up here in Phoenix, HEAL, and the Addiction Recovery Center. And then, of course, we have strong collaborations with the Moms Clinic in Tucson and then Hushby Nursery up here in Phoenix. So our strategy, we just received a large grant from the Corrigan Foundation to really start looking at how do we address that void in the rural communities. And so we will be rolling out telehealth services in Casa Grande and Maricopa starting January, and extending to Payson, Apache Junction, and North Country, ultimately Page and Northern Arizona by January 2025. I get these lifted a little bit before then, but we'll see how it goes. This is my team. I just want to introduce all the lovely people that have been supportive of the program. Dr. Labruzzo, soon to finish her training and fellowship. And then Dr. Brunson. We have Dr. Mercer, who's our psychologist. Jen, who's our clinical social worker, but therapist. And then we have two social workers, Claudia Gonzalez and Alyssa Daniels, who we hope to have sponsored so that they can be doing more clinical work in this space. And then Tiffany Smith and Tiffany Archer are our RN navigators. I'm hoping that we're going to recruit Tiffany to our space as she finishes her nurse practitioner position soon. And then all of this couldn't be done without my right-hand lady, who is Kristen Pineda. And she will soon have her doctorate, and hopefully we'll maintain her in this process. Funding is a big deal, and I mentioned that before. And these pie charts are not allocation amounts. It's just kind of where we started with the state opioid or the state targeted response. then the state opioid response, and then Bruce and Diane Halley and Robert Corrigan. So I wanted to just give a little bit of acknowledgement there. In summary, partnership and teamwork is essential to success. Leveraging public and private partnership has been essential and really where the sweet spot, I think, is. Stigma reduction is so important, educating on new approaches, supporting our patients, and then collaborating with our state agencies. I worked with many of the speakers that have been on this last couple of days, and it's been delightful to be a part of this. We've also been able to collaborate with courts and how we can meet them where they are and guiding patients into services and DCS and Arizona Department of Health Services as well. And with that, I would like to just show a couple of my favorite pictures. It is really beautiful in Arizona if you open your eyes and look at the colors. That is all I have for you.
Thank you, Dr. Manriquez. That was a wonderful presentation. And next we have Lauren Reed from Mercy Care. She's going to explore how we can take away the barrier of insurance coverage for substance abuse treatment.
All right, thank you. Can you see my slides?
Yep.
All right, very good. Thank you so much. My name is Lauren. It's an honor to be here with you today, nearing the closeout of this amazing conference. Today, I'm going to share about access to care through grant funding. As a note, this is relative to resources and grant funding that serve individuals in Maricopa County. I will say that in the next few months, Mercy Care is expanding to Gila and Pinal County, and will work with partners and providers in those areas that also receive these federal grant resources. I also think it's important to get to know me a little bit and why my path has led me here today to present in front of you. I'm a social worker. I just passed my LCSW test a few weeks ago, so that's very exciting. I've always been a social worker at heart. I love systems work and I love direct practice. I'm a mom of 3 children and I love all things maternal health. I spent a few years providing counseling to women with perinatal and postpartum mental health needs. And I'm also in recovery. I have had firsthand experience of navigating this system of care with very little knowledge of resources, and I still consider myself one of the lucky ones. 13 years ago, I was grieving the loss of my mom and I was actively using substances. I was frightened, I was lost, I was ashamed, and I was hopeless. I had no insurance and I needed help. I knew nothing about resources in the community and my family was just as lost. Navigating the system wasn't easy or cheap, yet I had some protective factors, including a relentless support system to help guide me to my next chapter. Why I'm here and talking today is because I know many people don't have that same experience or the same protective factors or access to the same support system. And I believe we as providers and as a system have a responsibility to be that relentless support system for the people that need it the most. The objectives that we'll talk about today is identifying the barriers to accessing care for uninsured or underinsured individuals, exploring solutions to reduce the stigma for people with substance use disorder, learning about grants that may fill the gaps of care for uninsured or underinsured individuals, identifying community partners that have access to this funding, and discussing community needs, thoughts, and ideas to continue to improve access to care. I wanted to share Mercy Care's overarching mission and vision, as I'm an employee of Mercy Care and here on behalf of Mercy Care as well. So the mission of Mercy Care exists to address and advocate for the comprehensive health of our members and families, including circumstances that impact their well-being. This includes special consideration for the underserved and those with complex health needs, regardless of race, color, religion, ethnicity, national origin, sex, sexual orientation, gender identity, age, or disability. Our vision is our members live a healthier life and achieve their full potential, and our values include compassion, innovation, collaboration, and advocacy. We have several strategic initiatives and community health focus areas, including supporting mental health and well-being, empowering recovery from substance use, addressing housing security, managing chronic illness, and caring for specialty populations, delivering excellent quality and services, and leading transformational care delivery. As we know in our working profession, there are a million acronyms. I'm not going to go over all of these, however, they will be in the slides because in the grant world, there are equally as many acronyms. So I'm sure we've heard a lot of data already throughout this conference, and as we all know the importance of data-driven care, here are a few more data points that from recent research that helps to continue to paint the picture of the importance of accessing quality and effective maternal specific care. The links to the research studies that this data came from will be at the end of the slides for your review if you're interested. So women are at higher risk for developing substance use disorder during reproductive years. In one study, 11,782 pregnancy-associated deaths, 11.4% were due to illicit or prescription drugs. Pregnancy-associated deaths because of drug use has increased 190% between 2010 and 2019. 34.3% of deaths occurred during pregnancy, 19.2% occurred during the first 42 days, and 46 occurred between 43 and 365 days. American Indian and Alaskan Native and non-Hispanic Black women were disproportionately at risk for maternal mortality. 240,000 children lost a parent to an opioid overdose in 2020. Women are at higher risk of substance misuse due to chronic pain, higher doses of prescriptions, misuse of prescription to treat other problems. One study showed that pregnancy may motivate women to get into treatment, but studies suggest that women do not stay in treatment long for some barriers that we may talk about in the next slide. And then 1.4 million children live with mothers who are single parents with substance use disorder. So now we will spend some time talking about barriers and stigma, which I know we've talked a lot about today. But the goal here is to really understand what gets in the way of accessing services and what may get in the way of maintaining the services that are in place. The more that we seek to understand, the more compassionate, empathetic, and creative we can be to address these barriers. For limited awareness of resources, many individuals and family have never accessed services in our system of care. For instance, that was my experience. I had very limited knowledge of what resources were available and didn't know where to go to ask. Many people locate treatment options through word of mouth. And unfortunately, I've witnessed a lot of misinformation about accessing services, such as the myth that you must have insurance before seeking treatment. That myth floats around the ether all the time. Relational barriers. Often women may hold a caretaker role in the family unit or lack the support to help with tasks that get in the way of accessing treatment. This could be for outpatient treatment or residential treatment. No insurance or underinsured, meaning they may not have adequate coverage to access resources. Childcare, as I shared in the data slide, there are many mothers who are single parents who don't have the resources for childcare needed to access treatment. Barriers to medication-assisted treatment services. There's a lot of stigma related to MAT or harm reduction techniques. Many people will say it's trading one drug for another. There may be practical barriers of accessing medication-assisted treatment, which should be considered when it comes to the program requirements and hours of operation. That may also have to do with the caregiver role. Staff attitudes, unfortunately, can also contribute to that stigma. We have a small window or opportunity of time to get someone through the doors and connected to services. And as helping professionals, we have to be thoughtful in our approach to help. There's also an internal stigma or fear of addressing substance use. As people that shared their story today or yesterday, you know, when someone's in active use, it's not typically fun. It's not fun anymore, or maybe it was never fun. It becomes survival. and whether it's to feel well or to function. I often say to people that people don't use substances to feel good, they use it to feel less bad. The fear of experiencing that can be enough to never seek treatment. That's why when someone is in a place to seek treatment, we must recognize how vulnerable they are in that moment. We must recognize that the community or cultural views of substance use may delay someone from seeking treatment. And as providers, we're responsible to care for ourselves and do what we need to do to address compassion fatigue, so we can continue seeking to understand the unique experiences of everyone that reaches out for help. To sum it up, when it comes to barriers and change, we must recognize that change is a process that requires a supportive environment, while also recognizing that many people do not have a supportive environment to change. Understanding this concept allows us as a system to begin to create that supportive environment for the individuals that we serve. Now I'll begin to share about grant resources, and I'll start with block grant funding. So it's a little bit more dry, but it's very important to understand about what this funding is and how it works. So a block grant is a non-competitive formula grant mandated by the US Congress. Eligible entities have to submit an annual application to demonstrate statutory and regulatory compliance in order to receive the formula-based funding. SAMHSA is responsible for 2 grant programs, the Community Mental Health Service Block Grant, or MHBG, and the Substance Abuse Prevention and Treatment Block Grant, also known as SABG. The 2 block grants are Substance Abuse Block Grant, otherwise known as SABG, and the Mental Health Block Grant, otherwise known as MHBG. Both are federal block grants that are designed to serve uninsured or underinsured individuals. SABG funding targets several priority populations that we'll review in the next slide. Individuals of any age can be served under this funding, but they must have a substance use disorder. For MHBG, there are 3 different populations that this funding targets, such as individuals with a serious mental illness designation, children with serious emotional disturbances, and persons 15 to 30 years of age who are experiencing their first episode of psychosis. For the purpose of this presentation, underinsured is defined as individuals who require necessary services that are not covered by their traditional access coverage. For the purpose of this presentation, we'll focus mostly on the overview of the Substance Abuse Block Grant and other funding that has priority populations of pregnant and parenting women. The purpose of the SABG grant is to provide funds and technical assistance from the Substance Abuse and Mental Health Service Administration to access, to use the funds to plan, implement, and evaluate activities that prevent and treat substance use and promote public health in Arizona. The Substance Abuse Block Grant has many overarching goals, such as ensuring access to a comprehensive system of care, promoting evidence-based treatment and gender-specific treatment, ensuring access for underserved populations, promoting recovery and reducing the risk of communicable diseases, and finally, increasing accountability for uniform reporting and outcomes. The Substance Abuse Block Grant identifies several target priority populations. The targeted priority populations in order of priority include pregnant women or teenagers or kids who use drugs by injection, pregnant women or teenagers who use substances, other persons who use drugs by injection, substance using women and teenagers with dependent children and their families, and all other individuals with a substance use disorder, regardless of gender or route of use. Pregnant women and people who inject drugs are the most targeted populations because it is more of a public health approach that addresses risk factors. Both populations have a risk of transmission of communicable diseases, and pregnant women's substance use would affect both the pregnant woman and her fetus. So there is a requirement that these populations need more attention and priority for receiving treatment. The goal of targeting these populations are to limit wait times and provide interim or in-between services so that they can get into treatment within the timeframes that are required. These are the covered services that come directly from access policies that help govern the way that we manage the grant. Services range from case management, living skills, medication-assisted treatment, and many other services that are listed on this slide. Here is the list of residential and outpatient providers that are subrecipients of this funding. My hope for sharing this list is to provide a general overview of what they do, is that you may remember the program name or know where to look or refer when you are working with someone who may meet the eligibility. We also have a link to our website on this slide too. You can also just search Mercy Care SABG and it will have all of the updated providers that receive that funding. Here's the list of opioid treatment providers that can provide medication-assisted treatment services with this funding as well. There are currently 3 24/7 access points to medication-assisted services in Maricopa County, ideally meaning that someone can call and access services the same day or within 24 hours. And here's the list of the housing and outpatient programs. Arizona Women's Recovery Center has several programs, including programs that may include supportive housing for pregnant women and women with children, outpatient and vocational and living skills. Community Bridges has a program called Center for Hope for pregnant and parenting women that may include supportive housing where they live on site, medication-assisted treatment, peer navigation, outpatient services. Center for Hope also has childcare available while women are receiving outpatient services. And then Oxford House is a self-run, self-supporting recovery housing model. So it's kind of a democratically run supportive housing. And the vacancy link that's right here will show in real time any openings that are available in their housing units. Currently, they have 11 women and children's houses with 4 in Maricopa County. Now I'll share a little bit about additional funding and or grants that Mercy Care oversees. Cost reimbursement funding doesn't typically cover direct services, but it is used to support infrastructure or expanding programs and unencounterable services. So here's a big acronym, the Coronavirus Response and Relief Supplemental Appropriations Act, otherwise known as CRSA. This funding was used to help these programs listed here expand services, including infrastructure and programming. Some programs expanded their outreach workers, medical staff, or invested in different types of treatment, such as music or art therapy for the individuals that they were serving. The State Opioid Response Grant, the overarching goal of the Arizona State Opioid Response Project is to increase access to MAT treatment, coordinate and integrate care, opioid use disorder and stimulant use disorder recovery support services and prevention activities, to reduce the prevalence of opioid use disorder and stimulant use disorder and opioid-related overdose deaths. SOAR centers on the unified goal of improving access to and participation and retention in medication-assisted treatment services to treat OUD, improving access to short-term and long-term substance use disorder recovery supports by sustaining those 24/7 access points, sustaining and expanding peer support, sustaining and expanding early identification of MAT eligible individuals re-entering communities from correctional settings, sustaining and expanding coordination of care and warm handoff for post-opioid related events in hospitals. So we actually have navigators, one of the providers has navigators in a hospital that helps with that coordination of care, sustaining street-based outreach, sustaining and expanding recovery and supportive housing.
Lauren, can we interrupt you for a quick question?
Sure.
Before you move too far away from talking about treatment, places you can go for treatment, Carrie English asks, are all of the housing places OUD, SUD treatment only, Or do any of them also treat pregnant postpartum dyads without OUD, SUD, who are having acute psychiatric care needs?
Ooh, that is a good question. So they have lots of different programs, and they on their website will say the different housing programs. I would say Center for Hope is their housing is for substance use. So you have to be pregnant, you have to have a substance use disorder. Arizona Women's Recovery Center may have some programs that I'm not familiar with that aren't related to this grant funding. And then there's also several programs in the community, you know, that may help with that, that aren't substance use disorder related, like Maggie's Place, UMOM, you know, some of those community resources as well. And I'm happy to provide additional resources too, if you want to reach out.
Okay, thank you.
Absolutely, thank you. Sometimes I move too fast too, so. So back to the state opioid response grant. This is the list of providers that have that funding. Next is the Governor's Office Substance Use Disorder Services, otherwise known as GOSUDS. So GOSUDS is a funding source administered through the state in order to increase member access to substance use related treatment and navigate our existing network. GOSUDS is what is known as payer of last resort, meaning if the member doesn't qualify for any other grant funding types, they may become eligible for coverage through this funding. GOSUDS also provides an opportunity to access treatment for individuals with limited behavioral health insurance coverage or high deductible plans. Here's a list of the providers that offer or have that funding available. All right, next I will share about additional, Next I'm going to share about resources and our call to action. So now we can look a bit at some of our own action items, starting with our perspective and our approach. Some old perspectives are filled with the belief that if you want help badly enough, you'll find it. In an ideal world, that may be true, but it does not consider all of the barriers that we discussed earlier in this presentation. It's important to publicize services, brochures, resources that are easily seen or available. It's important to target outreach and ask questions. Sometimes that's all it may take. Someone seeking help to address substance use is in an incredibly vulnerable and fearful time in their life. And I'll also say just women who are recently postpartum, you know, life is turned upside down as we've learned about. You know, there's a lot of things that women may be experiencing that they're afraid to even bring up, whether that's scary thoughts. You know, when I worked worked with women in counseling, you know, I talked a lot about that with them, and I wouldn't know unless I asked, because there's that stigma of sharing. Treatment and programming is often designed in a world of ideals, yet we also recognize many barriers or personal preferences that require that flexibility. We need to continue to recognize that treatment and recovery are not linear, and the best way to support is to offer an array of services that are flexible and based on client choice. As we've learned with trauma-informed care, a lens of mutuality is imperative in care. Collaboration and shared decision-making allows for more buy-in and better outcomes. We can continue to incorporate diverse supports, including non-traditional supports defined by the individual. We can hire more peer supports in direct services and in management. Peers can and should be a part of the decision-making within an agency. Peers make a difference. Treating individuals only for substance use disorder is simply only treating a symptom. It's the beginning of a long path of self-discovery and healing, but it's not the beginning, middle, and end. Women who are parenting and in early recovery or seeking treatment are in a unique position that likely will require or benefit from diverse supports and treatment services that focus on the whole person and the whole family. Services from prenatal care, education on what to expect after baby is born, normalizing the experience of early or new motherhood, including exploring shifts in mood, normalizing the fear that often comes with early motherhood, education on child development, assistance with childcare, that's a huge one, parenting classes, attachment or trauma counseling, and physical health care. The list goes on and on. I will also say SABG funding does cover childcare. We're working on kind of figuring that out with all the providers that may offer the childcare as well. And finally, recognizing that abstinence may not be the goal of every individual that you work with and that's seeking treatment. Recovery is self-defined and there are many paths to the same destination. MAT services may be time unlimited depending on the individual need. It's imperative for the individual as well as our own wellness and the helping profession to check in about our own expectations. And we want to celebrate the wins. At the very least, we create an environment where someone feels safe enough to make mistakes and excited enough to know we are always cheering for them. So here's our call to action. I've seen a lot of great themes throughout this presentation or throughout the conference on things that we can do in our day-to-day work, such as using strengths-based person-centered language, remembering that words matter. There's a few resources embedded in this presentation and in WOVA that offer some suggestions in our daily language. Another theme that I heard quite a bit includes increasing screening tools that identify substance use, risk, and mood disorders. Also recognizing that if we don't ask, they likely will not disclose. Educate your agency on community about grant funding. Help to challenge or debunk the myths that float around about accessing care. Use the resources that are available, including the SAMHSA treatment locator and the Access Opioid Treatment Locator that'll give you real-time information about providers that have openings. The Mercy Care website and other resources that you receive through this training. Feel free to reach out to Mercy Care for any marketing materials such as posters or brochures on SABG or other grant funds. And our department would be also happy to set up any presentations or training for your practice. Can't emphasize enough the importance of building relationships with grant-funded agencies for that effective coordination and referral. Ask for presentations, brochures, or flyers. Putting a face and to the program makes a difference. And continuing to be that lifetime learner. There's always new changes, new programs, and newer, better interventions that we learn along the way. For this specific population, there's the PPW PLT collaborative through Access. Also, those ASU echoes that focus both on MAT and gender-specific treatment. You can gain CME credits as well. And then increase that office-based treatment providers who can offer MAT services. There's a training link in this slide that can help providers get the X-waiver training, I believe, for free. So members or any individual, you don't have to be a Mercy Care member to receive these funding. I want to make sure that that's also important to know. But they can call the phone numbers that are listed here, and then there's our contact information. We talked a little bit about the federally qualified health centers. So Mercy Care recognizes that recovery also includes addressing areas of wellness that are unfortunately not covered by the grants, such as physical health. These federally qualified health centers can help address those needs, along with substance use services as well. And then here's the resources, including the overdose prevention toolkit, the words matter, and the substance abuse treatment addressing the specific needs of women. Here's all of the access policies that help govern our administration of the grant. There's our contact information again and the references, and that'll do it. Thank you so much.
Thank you, Lauren. That was wonderful. I just want to say thank you to our distinguished panel, and also thank you to all of the presenters over the last 2 days who worked so hard to present such quality information. I think we've been extremely lucky. And before I turn the podium over to Martine again, can I just say thank you to Dave Ryder, who does such a spectacular job with these presentations and pulling everything together and making sure we're all in line. So you'll never know how much work he does. Okay, so Martine, I'm going to pass the podium back over to you now.